My name is Igor Volovich. I'm the former CISO of Schneider Electric and Invensys, and currently in DC running Cyber Strategy Partners, an advisory and a strategy consultancy. And today we're joined by Dr. Jordan Tannenbaum. Doctor, go ahead.
Well, thank you. I am the Chief Information Officer and the Chief Medical Information Officer here at St. Peter's Healthcare in New Brunswick, New Jersey, which is a 478-bed teaching hospital that also has a children's hospital. And we run about 28 clinics throughout the community. And we have a medical staff of about 1,000.
Very good. Well, thank you for joining us today. So we'd love to talk to you about, obviously, a lot of the challenges that are inherent in the technology space and the healthcare system, and especially the challenges you've had in the last 18 months or so. And of course, everybody has faced them, but I'm sure you have felt them more acutely. Of course, you have patient care, you have human lives are at stake, and I'm sure that makes the mission a lot more palatable, a lot more acutely felt across the entire team. So maybe you can tell us about some of the challenges that you have faced personally and the approach you have taken to overcome them.
Right. So, in the healthcare system, obviously during COVID, the entire issue is separation and no contact while taking care of patients. That was like the challenge. To the best of our ability. Obviously, there needs to be patient contact for people in the hospital. So there was a lot that went on. And the first thing, of course, was we wanted the non-essential people who did not have to be on campus or be together at all to work remote. And we were fortunate in that, we were already a Zoom shop. We're migrating to Microsoft Teams. The entire IT team was already on Teams, and they already had laptops, and we got them. One afternoon, we said, everybody go home, do not come back until stated. They have not been back yet. And we became a remote workforce for IT immediately, except for the people who need to be here hands-on. Then we went on to other areas like finance. Finance was partially remote. We made them fully remote in 2 days, got everybody out and provisioned them with the right VPN access, with the right apps to be able to access the apps they needed remotely. So I would say within 2 days, we had everybody that could be remote, safely remote. So that left a lot of other challenges for patient care. One of the problems was, observing patients. Every time a nurse had to go into the room, or a doctor, or anybody, during COVID, you needed the full PPE, which is the goggles, the masking, the gown, and the gloves. Now, PPE supplies, if you remember, were in short supply. It was very difficult to get. So you wanted to limit that contact for routine things. And what we did is we set up remote cameras in every room with a central person in a kind of a control room that could monitor all the COVID rooms. And then when we got a lot of COVID patients, we made 2 monitoring stations. And all those cameras fed into a bunch of monitors, and an RN sat there and was able to communicate both to the patient and to the nursing unit anything that needed to happen that was routine. So somebody, needed something and the nurse didn't have to go in just to find out what they needed. That saved time and that saved PPE. So that was a big thing. The other thing we had to do, which was really a challenge and very sad, is that, a lot of people did expire during COVID, and we had no visitors. And we did set up tablets, iPads, so people could communicate with their families, or the family could at least communicate with the patient and have some communication during those last hours, which was very sad and very difficult on everybody, but did enable that to happen. And then, we also were enable it to happen to people who weren't terminal, but that was key there because, we really felt that there should be family communication. Obviously, the families did as well. So we had to come up with those solutions, which we did. And then, of course, the other thing was, okay, the clinics are closed. How are we going to talk to the patients? Well, that's telemedicine, of course. And we had a telemedicine solution, but it was kind of, we're actually just before COVID, reevaluating, do we like the solution or not? It's a little bit clunky. And then CMS came out and said, hey, you can use kind of basically anything that works. We're not going to hit you with any HIPAA stuff if you use like FaceTime or Duo or something like that. But so we started with those, but the issue with those is that both the patient and the provider have to have an account and set up everything. And also, once the interaction happens, the patient is actually able to call back to the provider, and that started to create confusion. Mm-hmm. So we found a different solution that existed already that was very simple to implement. We used that. And then what the advantage of that solution is, the patient just got a text with a link. Mm-hmm. There was no download, there was no sign in. They just clicked the link, it came up, and the doctor was able to connect without revealing, his information or her information, and be able to have a virtual visit. And then the company we use for our EMR did a spectacular job of incorporating telehealth into their EMR as a native part of their app. And when that happened, we just converted to that, and we're still using that today. It works very well, and it made everything centralized. We take notes and talk to the patient at the same time, bring in other people. And so, the push to virtual medicine was happening before COVID, and COVID just like gave it this huge acceleration into where it should have been a while ago. And of course, it also allowed waivers on a lot of the rules that were holding back telemedicine, especially in Medicare. So, those were some of the major things that we did. Then, of course, we have no patients, and we're spending money because we have COVID patients, but we don't have elective surgery, we don't have regular patients, we don't have outpatients. So, you get real smart about your spend and look at what you can, do without, what you can aggregate and reduce your spend, and kind of approach your vendors with a much sharper pencil. And that actually helped as well. So it was a conglomeration of all these things that were kind of nascent and then just rose to the surface, but all at once, and rushed around. And the other big duty that we had was reporting. We run decision support, and everybody and their brother wanted to report on something, and especially we were very fortunate in New Jersey in that New Jersey worked with the hospital association so that the hospitals reported just to the hospital association. Hospital association disseminated that data both to the New Jersey Department of Health and to the federal authorities that needed the data. So we only had to input the data once, and it went where it needed to go. So that was a blessing. But that data requirement changed all the time as the pandemic changed and we understood it more. They were looking for other data. And our data team initially, the first 2 or 3 months, they were working 7 days a week to pull the data and we had to create on the CMIO side, and using my CMIO hat, we had to create ways to record that data in the medical record. The medical record didn't have a COVID, module. So we had to create, fields and workflows to flag COVID patients and their results and their outcomes and testing and all that. And initially there wasn't even a code for COVID. COVID didn't come out for a couple of months after it was really declared a pandemic. So, it just took a lot of work on everybody's part, which I'm sure you've heard from your other interviewees as well.
We certainly have, yeah. And recently I spoke to the chief of data analytics over at Stony Brook, and he shared with us some interesting perspectives on just dealing with all that data. And actually what they were dealing with in New York, they didn't have the benefit of New Jersey's allowance of not having to share data with multiple different providers, but actually having to share it with just one, like you're doing. So they were challenged by having to send out data to multiple instances and then different formats and different schemas, and of course that creates a lot of issues on the back end. Of course, they had limited bandwidth as is when the whole thing began, and then of course now they were challenged additionally.
Sure, that person must have talked about data definitions, because before, what is a COVID patient? If somebody, has a positive test, which test, and what if they don't have a positive test, but they have every symptom of COVID? Is that a COVID patient? How are we defining this? So if a patient comes in with a major comorbidity like a cancer or a heart attack, and they also have COVID and they pass away, what was the defining element? There's a lot of subtleties, a lot.
Yeah, I mean, I'm sure that's, of course, because this whole topic has become so politicized, the question of statistics and what is the actual cause of death and et cetera, that's very important. And so you kind of wind up being at the crossroads of that as you're the data provider. So you're creating those data fields right now as we speak. And so that's very important that people feel there's integrity in that, and also the data is not getting confused, and making sure that that data sourcing is entirely visible and transparent. And so that, of course, that's challenged by the fact that there's HIPAA, and you also have to protect that data. So as you're sharing, you have to protect it, and so everybody has to be a known entity, so that there's challenges there. Of course, all of that is further complicated by things like ransomware attacks and all the medical facilities that are being targeted right now, despite the fact that we've heard from these bad guys, Revil and some of the other criminal groups, that they're saying we will not be attacking medical facilities. And of course, here comes another group, and they say, well, we're not bound by these commitments or these agreements or any of that. We have no ethics. We're going to attack anybody we want to, and then they do. And of course,
and the other part is, Igor, I don't tell you, ransomware is a service. They get these affiliates, which are people that just download this stuff, and work with them. They have no idea really what they're doing, except that they can get the payload into a socially engineered email and hit something, and they'll hit anybody. They don't care. And I always say it's like giving a kid the key to an atomic bomb. I mean, that's exactly what this is. And so there was no stopping any organization or person from targeting anybody, especially healthcare organizations. And of course, the government said, you got to be on high alert, and we always are. I think that the number one thing that I know keeps me awake, and I'm sure keeps every CIO you talk to awake, is ransomware and what we can do to reduce that risk. Because it used to be in the old days, as the big thing is, well, they'll steal your data. They'll steal your data and sell it. And that was bad for the organization, especially in healthcare. You get a lot of fines. You get your reputation is hurt by that, but you didn't have a business interruption. But here, you're going to have a business interruption that could be devastating, and that's very frightening to every CIO. And it requires, I think, and what we do, and we have a very sympathetic board. I'm very fortunate there to say, listen, there needs to be investment in the right things here to reduce our risk, because the risk is not just that we stop working; it's the cost of lost business, it's the cost of reconstruction, it's the cost of the consultants. It's a lot. Even if you have backups, it takes a while. So it's a huge thing. I mean, I think it's the biggest thing right now, honestly.
It certainly is, and everybody's thinking about it from not just technology, but also a policy perspective. How do we stop it? How do we deter it? And I think, and I've written about it for a long time, and I've spoken to a lot of folks in the industry about it. I used to be a part of a program called Botnet Task Force back in my days at Microsoft. This is taking us back 20 years now, almost. And Secret Service and FBI and DOJ partnered through Interpol to work with the private industry and other law enforcement intelligence agencies back then. understanding the threat of malware, understanding the criminal enterprise component of it, and the fact that it was being driven by profit objectives, and folks were getting in on the game. Back then, there was some proliferation mitigation, let's call it that, because you did need technical tradecraft and capability. So it was limited. You couldn't just go and get it. You couldn't spend $500 and be in that game. You had to actually have some knowledge and experience and expertise and some infrastructure and resources. You couldn't just wake up on Monday and be in the ransomware game by Tuesday, or by Monday evening these days. So at least there was kind of a constricting factor there, a constraining factor, but it's gone now. Now, as you said, and I think it's a very astute observation, anybody can be in that game, and the price of entry is minute and almost non-existent. I mean, we just saw a recent news story about a Russian, I think, grandmother who was actually acting as a project manager for a criminal enterprise, and she didn't know a whole lot about it. I think she was basically a web developer at most, in terms of her skill set, but she became kind of a den mother for this gang of criminals, just operating as their de facto PM and just managing their efforts. And these are the kinds of folks that are now in that game, and you don't have to be a hacker, quote unquote. You can just be a run-of-the-mill person who has no criminal background, but then you become a criminal the next day, and then the industry is enabling that. So that's the scary thing, is the proliferation and the availability and the low barrier to entry. And of course, we're the ones catching that flack. And to your point also, not only are they grabbing your data and locking it up, but they're actually doing the double ransom, right? Where they're going to lock it up and they'll release it. So if you want it, you can just wait, don't pay, and then you'll catch it out on some download site. Of course, it won't be in the format that you have it. You'll have to get it back somehow. So it's very scary, and I sympathize with you and folks who are in your role. You're protecting the holiest of the holy, folks. I mean, next to financial records, medical records is one of the things we hold dear and sacred, and certainly in the Western world, we consider them sacrosanct and part of our privacy sphere, and we depend on them being secure. And of course, that's kind of gone off by the wayside. I think a lot of folks have accepted this notion of the eventuality of compromise. The breach will happen eventually to everyone. And I think a lot of folks have also accepted this kind of a fatalistic philosophy around it, where they say, well, we're going to get breached anyway. What's the point? What's the point of prevention? Let's just focus on response. Let's focus on mitigating the threat, or mitigating that blast radius, or mitigating the impact. And of course, there is no mitigation. Once that data is locked up, that's it. You're done. Your mitigation is hope you have a backup, and hope you can restore operation.
Exactly. Backup is the key, and it got to be really technically, depending on your network, air gap, and that's hard to do on a large scale. There are a couple of methods out there, but it's hard to do. You just can't plug in your little hard drive into your EMR and take that out.
Right.
But yeah.
That's a challenge. So I'm curious, what are your thoughts on cloud? So of course, everybody got pushed into the cloud. You talked about telemedicine and relying on your EMR provider to actually develop that feature for you, where it became embedded in your platform. But what are your thoughts on cloud? Of course, acceleration was tremendous over the last 18 months. A lot of folks who weren't ready for the cloud wound up in the cloud with all of the entailing problems with that. And we've heard a statistic that most vulnerabilities out there today in the cloud are actually misconfiguration vulnerabilities, not software problems. So curious what your experience might be. Of course, don't share anything proprietary, but we'd love to hear your kind of general opinion.
Sure. We're very conservative about the cloud. We don't have a lot of primary, certainly we have third-party vendors that we use that have their stuff in the cloud, but our stuff is basically not in the cloud. Mm-hmm. But the thing that's in the cloud, which is not a surprise, is Office 365, right? So that's in the cloud. So we do back up we have a separate, not Microsoft backup, but we have a separate backup system that backs up that cloud to another cloud. So if that gets hit, we have a way to recover. And the other benefit of that backup is, I believe Microsoft's, retains data for like 30 days or something. We can get all our data back, all our emails back, everything back, if we need to, and use that as a repository. Also for legal stuff, when they go back and they want, your email from 7 years ago that you sent to somebody, we can get that. So that solution we put in right away. We realize that we're at risk there. you're kind of depending on your cloud vendor and the knowledge of your staff to be able to configure, to your point, everything correctly. And we said we better have a backup on that. I mean, to what you were saying earlier, yes, we're big on prevention and detection, but the biggest thing is getting the backups in place and keeping them pristine, so that if we do get hit, we have some chance of recovery.
Mhm. That makes perfect sense. Yeah, of course. I mean, it's sustaining operations and serving the patients and keeping your doors open. That's the big thing. That's what you're there for. And of course, you are a community health system. And so people rely on you in a very tangible, very near home way, right? You are the local game in town, and that's what they need.
The other part of that is your downtime procedures.
Mm-hmm.
How familiar are your staff with downtime procedures? Now, for the big thing, which is the EMR, we have EMR downtime. Mostly scheduled, sometimes not scheduled. And they're used to that, at least for short term. They can get through, we know that they can get through up to 24 hours without EMR. Longer than that, it gets a little difficult, but it can be done. But, we still have communications, we still have our finance systems, we still have everything else, our building systems are intact, all that's intact. So yes, you can continue to operate, but if they also hit your IP phone system, your VoIP system, and they start to hit your building controls, and God forbid they hit your medical devices, I mean, you're looking at a serious, dangerous situation. And have been hospitals that had to move patients out. They just had to shut down.
Yeah, we've definitely seen that.
Yeah, we never want to be in that situation. I'm not saying we won't be, but that's where we don't want to be. We want to try to prevent that whole scenario.
I'm curious, what would be your recommendation for fellow peer practitioners in your field who are just starting out on that journey or trying to kind of get a hold of it all? They're casting a net across the enterprise. They're trying to understand what it is they're facing with. Maybe somebody stepping into the role, new hospital, new health system, and they're taking over a role. What would you recommend be their first activity to kind of figure it out, figure out where they stand, what their maturity state is today?
Well, I mean, that's a big question. I think that basically you have to understand what you're sitting on. You have to understand your assets and the priority of those assets. What does the asset do? And in a healthcare system, is it mission critical? If this turns off, will somebody have a negative outcome that's serious or not? And then, you work it down from there. And once you have your assets and that includes your whole network infrastructure, it includes all your DNS servers, it includes your firewalls, it includes everything. And once you know what you're sitting on and you prioritize it, then you start the process. How are we protecting it? How are we, monitoring it? And how we're going to recover if it goes down. I mean, we just use this framework, and that's what we think about. And, we make sure that our configuration files are backed up separate, those kind of things. So, I mean, I think that's just basic. I'm sure there's more to it. I think we do use some consultants to help us guide us on these things. And I don't think, especially if you're starting out, it's a bad idea. I don't think it's a bad idea. I think that they can be very helpful in taking that acquired institutional knowledge and passing it on, because it's easy to go down to miss something. I would say the easiest thing is to miss something that's critical.
That makes perfect sense. So rely on your friends. Don't go alone. Bring someone, right?
No.
Rely on your technology partners. And I think there's a question there too. How do you ensure that you pick the right partners? How do you ensure that, of course, there's an enormous amount of lock-in, especially in the industry with big vendors. You pick a platform, you're stuck with them for years, if not decades. And some folks still have mainframes running around because there's so much invested and so many processes built around it. It's hard to uncouple from that and kind of grow past it. And luckily, of course, a lot of vendors recognize that, and so they try to build more capability, more features,
Right.
newer capabilities, and that's great. But also, how do we, as consumers of all that technology, maintain that clarity of purpose from our end, where we're not so much driven by technology, kind of bottom up, but mostly driven by our objectives, our outcomes, and of course, for you, the patient outcomes,
Right.
and ensuring integrity in those decisions. I think that's the big challenge, and of course, that's why you've got the big seat. That's where you make those decisions.
Yeah, I mean, it's true. When we look at everything, yes, we have to figure out how is this going to impact the operations, which everybody does, and how are we going to, how does it affect IT? What is the load on IT? What is the risk to IT? And then, of course, the usual stuff you do with a vendor, their financial position, their support, and all those things I don't have to,
Mhm.
mention.
Right.
Everybody does. But, for us, choosing the wrong vendor in a critical situation could really get us into trouble. On the other hand, I will say that in the healthcare field with patient-facing uh, solutions, there's two things. The weak do not survive, because if there's negative out there, nobody's going to risk it.
Mhm.
And some of the heavier stuff, for instance, our EEG systems, are FDA approved. So not just anybody can get into the field in the first place, because if you know anything about FDA approval, it's an arduous process for medical devices.
Mhm.
So there is some kind of a barrier there that weeds out the weak.
Mhm.
So yeah.
That makes sense. Do you also think that the regulatory climate within the healthcare space, and this is kind of a broad question, not necessarily relevant to your specific role within your health system, but kind of a broad trend idea, do you feel that the regulatory climate is encouraging innovation? Do you think it's stifling innovation within the space?
I think it's trying, at least from it. I think it's trying to encourage innovation. I don't think they were able. I think with meaningful use
Mhm.
and the ARA money, and they got everybody on the EMR, and I think that was a good start.
Mhm.
Uh, I think, and from the physician side and from dealing with physicians for years now, we know that the original EMRs were not written by healthcare people. They were written by programmers who thought like programmers, and that's why it's frustrating for clinical people to use them. I mean,
Mhm.
that's a very short story, but that's the bottom line. So, I think as things have progressed, they've listened to the clinical world and made it more useful to clinical people over time. But I think what needs to happen, and from the government point of view, is they were surprised, even though that interoperability was built in to the goals, it didn't happen, and they had to go back and mandate it, come up with a standard and mandate it, because what happened with the vendors is, of course, they made their products very proprietary and difficult to exchange information with anything. If it wasn't an equivalent EMR from another, of the same brand.
Mhm.
And that was, I think the government was surprised by that and didn't account for that in the rulemaking. So they had to go back and make all these interoperability rules. Then they had to come up with the information blocking rules. So there's a lot of rules just to push forward interoperability. And I think that the push towards having patients being able to get their data from multiple sources and aggregate it into one independent source is a good thing if the data is good, and we have a lot of not so good data in healthcare, and conflicting data. So, when patients see that data, they're often surprised that, oh, I didn't know I had that, or maybe I didn't have that.
Mhm.
Or this doctor said this, and this one said this, and they're not compatible. So you find that out, but then it's your opportunity to correct it and clean it up or understand it. So I think, the general trend of the government is trying to get more technology. I mean, I wish they would make telemedicine easier.
Mhm.
I think they were really behind on the Medicare rule that just said telemedicine is in rural areas. I think that was a huge miss years ago, and I think they found that out with COVID, and I'm hoping that they keep that going. I believe they are. That we can use it in general, and I think that would be a huge improvement in care, especially for the elderly and people who have challenges getting access, especially at a distance.
Absolutely. That's very insightful. I appreciate you sharing that, your thoughts on that. I think a lot of people have engaged with telemedicine for the first time in their lives during the pandemic. And again, we got forced into these new use cases, and then suddenly people found out that they liked it. And even though it was driven by something awful, the ability to do it was there. And now, as we're starting to pull back from that again, you can't write prescriptions across state lines, so you can't see patients for the first time. You have to establish care actually in the state before you can do televisit. That's problematic, and of course that goes back to regulatory climate. That goes back to some of the things within the states and the way that medical boards control access to care to a certain degree, which might be a little bit about competitive and anti-competitive. Right, so we get that, but I think the patients are driving this trend towards more access, better access, easier access.
Well, I think that patients are driving a trend toward consumerism that is huge and totally underestimated by the industry. Some hospitals really get it, and they have very impressive programs. And again, that's another maturity journey we're trying to get to. But you look at how you buy stuff. And how you get things done, and how you go, get a ride nowadays. And then you look at what medicine does, and medicine's like, 20 years behind. And the patients, who are the consumers, they want that same convenience. They want that app, they want that visibility, they want that instant response. And it's going to be up to the medical field to redefine itself in a way that it can deliver that in a safe way and effective way, or at least triage people on that basis. I had a thing where my daughter wasn't feeling good, and I said, "Oh, honey, make an appointment. I know you're not feeling good. I'll pick you up and I'll drive you over to the appointment." And she goes, "Dad, I'm just doing a telemedicine appointment." And I was like, "Oh yeah, you could do that."
I just need a script, and that's okay. And by the way, the pharmacy will deliver it to me, so I'll never have to leave the house.
Exactly.
You can go to the doctor, go to the pharmacy.
Field, I'm sitting there thinking, yeah, that's right.
Well, and I think that's the other thing. I think our generation, and I'm sensing that we probably are of different generations, but within our lifetime, we have seen this tremendous shift.
Oh yeah.
And then we look at our kids, and we look at our grandkids, and we realize that they have experienced this from the beginning, from cradle. They have known nothing else. They have never been alive before the internet. They were never alive before Amazon even, right? And Google, and all of this information is accessible. They've come to expect it. They demand it. That's table stakes. So if you want to play in any field at all, we used to say, well, there are some industries that are not susceptible to this disruption. And I think we've come to understand that none are. That we're all in the same technology, data-driven, consumer-driven, game. This is how it is, and people also want to own their data. There's this other understanding where it's becoming identity-driven, data-driven, and when we talk about IT concepts and security concepts, the perimeter has gone away. Everything's in the cloud, or at least it's certainly striving to be in the cloud, and data wants to be free. And to me, we used to look at it from a technology perspective. We should put it in the cloud because it's more convenient, because it's faster, because it's cheaper, it's easier to develop things. And as we conceptualize things like microservices and make things a lot more no code, low code, just kind of string things together, slap them together, it's all prefabbed, and you just you think about functionality, not how it's done. And now I think we're evolving to this even bigger understanding of the functionality is now how we get things done, but it's really all about the outcome. It's about the outcome, and then that's driven by the patient or the consumer, and they want certain things. They want that convenience. They want that access immediately. They don't want to plan. They don't want to wait for 2 weeks for an appointment. They don't want to wait, 3 days to go see somebody. They want it now, and they will look for. I think once the regulatory climate matures as well, where we can't consume medicine like we consume anything else, I think we'll see a different competitive market emerge.
I totally agree with different players. who are good at this already in other realms.
Mhm.
And I think there's a different attitude also if you think about privacy, right? So, I'm the generation where all my data, I don't want to share with anybody, there's a zero, I don't trust anybody kind of mentality
Mhm.
where I think what I see, and this is just my personal observation, is some of the younger generation say, I'm going to give up some of that privacy in terms, in turn, I will get value because I get customized information
Mhm.
back to me that has value because I gave them information about myself.
Right.
And they think that's a good exchange. I'm not judging that that's not a good exchange. I'm just saying they think about it differently.
Mhm.
They think about, if I give my email out, if I give if I give all my financial information out and let them look at my credit record, I can get a mortgage in about an hour. And it's like, okay, but you can do it. And it's a matter of what you're giving up versus what you're receiving.
Mhm. Right. Well, I think the way we have historically looked at privacy, again, very sacrosanct, very kind of traditional view of, my information should not be shared. I should keep it. And now it's become more of, I want to be able to control who I give it out to, but less from in terms of protecting it, but more from the terms of what can I get for it,
Right.
and using it as currency in these transactions where you're, like you said, you're playing off your privacy against some consumer objective, which is typically convenience and ease of access. And so I want to be able to buy a house online. There you go. You want to buy a car online. There you go. All you have to do is share your credit. And we're getting better at understanding these trends, but I think the industry has been mostly reactive. And when I say industry, I mean broadly. But I think consumers will have to be smarter about it. And like you said, the millennial generation and folks after that, Generation Z, they're not as concerned. They've grown up in this atmosphere where, well, data is everywhere and my data has kind of been out there, and so what? I can't pull it back in, so might as well get some use out of it, I think is the
Which puts an onus on us from the technical world to really do, the good protections, the dual factors, and all that kind of stuff to try to make sure that, okay, we're asking for the data to deliver you value, but we also have an obligation not to have that data, usurped in any way that was worked against you. So, it is you get the data, but you have responsibility for that data. And I think that's a tall order.
Yes, indeed. Well, do you think, I'm going to leave you with this last question, I guess. Do you think there is a room for the Amazon of medicine with the way things are going now on the technology side?
I think there's a couple of renditions of that, that I get that question a lot. I think there's a lot that can be done much more efficiently with I'm going to say, the touch of a button kind of thing. But really, there comes a point where, depending on what you're seeing a physician for, it can't be that simple. If you have a complicated situation, you need surgery, then everything, that whole paradigm doesn't always fit. Now, there are parts of it that you can still use, we use an app that prepares, for elective surgeries. So some elective surgeries, we use an app that prepares the patient for surgery, gives them a video, teacher, and then asks them, you're not supposed to eat anything after 12 o'clock. Just want to remind you, and takes them through the pre-op prep, and both educationally and a reminder. Then afterwards, well, we check in with them virtually. How's your pain today? How's your mood? Do you have any problems? And depending on what it is, very specific to the procedure. So that, that brings the kind of the checkup into the virtual area. But the actual procedure, so far, even with a robotic surgery, it's still handled.
Right.
So, there's a limit. But I do think we're going to see a much bigger, and I'm the one. I mean, the role of AI in medicine, I think, is the next big explosion here. I think there's going to be a lot more kind of data-driven recommendations, decision making that will kind of ease some of the friction that we have now in terms of diagnosis and treatment, and especially in genomic medicine. I mean, I think it's going to be huge.
That makes perfect sense. Well, I mean, we're collecting a lot of data already, and folks are, as we said, a lot more attuned to being able to share that data if they can get something out of it. And of course, the health and their health outcomes is kind of the ultimate stakes. If they can get something for that, perhaps they'll feel a lot better about sharing that data, of course, with the privacy controls and with the security controls built in. But if we can improve patient outcomes, ultimately, then it's all worth it. And if AI is the way to do it, ML is the way to do it, we're seeing some interesting use cases being developed at the insurance carriers where they are collecting a wealth of information, a lot more information that maybe anybody's comfortable with if they only knew. But they're doing some interesting ML training scenarios where they're finding patterns that they didn't even know existed. And of course, a human could never do that. And it would be impossible to imagine a single physician could do it, especially with the overhead that they have now. I mean, we have a physician in our family who sees 55, 60 patients a day. And it's incredible. And it's hard to imagine the quality of care to be there throughout those engagements. And so you have to rely on that data-driven analysis, and you have to have that automation built in. And as long as we can build it with integrity and make sure that, again, we maintain that security, create those positive patient outcomes, and deliver care that we want, then I guess it's all worth it in the end.